Greetings everyone, this is Yazan Melhem, a 5th-year student from the College of Medicine, University of Sharjah. Today we're going to discuss about secondary hypertension and how to classify the causes of secondary hypertension. So secondary hypertension is hypertension due to an underlying medical condition or disorder. And some of the conditions which allow you to suspect secondary hypertension include having it at a young age. This is usually a concerning time where we consider secondary hypertension if it occurs at a young age, especially less than 30 years of age, although it can occur at other ages. They have some causes or associations with each age group. Treatment-resistant hypertension can be also a point where we consider secondary hypertension. Treatment-resistant hypertension is when hypertension persists despite using 3 medications or more to treat hypertension, and each one has different mechanisms of action, and one of the medications is at least a diuretic. So in that case, we should suspect secondary hypertension. If we also have hypertensive emergency with organ damage, this could be also a sign of secondary hypertension that we should look for. If it has worsened when previously it was controlled, this could also be due to secondary hypertension. And there's also electrolyte imbalances such as hypokalemia, which is associated with one of the causes that we're going to talk today. Then we should also think of secondary hypertension. We're going to talk about all these today. So the cause of secondary hypertension, to make it look organized and classified, we go from head to toe. So we think of endocrine causes, and then we have respiratory causes. Then we have the renovascular disorders, which include the renal component, the renal parenchyma, and also the vessels, blood vessels. Then we go with other causes such as the drugs or medicines, and miscellaneous, which includes other causes, so as to make it organized and classified. So we talk with endocrine. We also go again from head to toe. So we go to pituitary first, and then we go with the thyroid gland disorders. Then we have the adrenal gland, and the adrenals we have adrenal cortex and also have adrenal medulla. For pituitary diseases, think of acromegaly as a cause of secondary hypertension. This is usually due to growth hormone secreting pituitary adenoma. And what would make you think more about it is when you have the external features present on physical examination, which we're going to talk about in a minute. And also you have some laboratory investigations which are positive, such as increased insulin growth factor 1. And then you can also do some confirmatory tests, such as oral glucose tolerance test to confirm the diagnosis. Other tests are present, and what you can also do is an imaging study, such as a pituitary MRI, so that you can look for the enlarged pituitary gland. And these are some of the features of acromegaly. You have here the prominent chin, and also enlarged nose, ears, and also enlarged jaw, and also enlarged tongue, and also enlarged feet, and also the hands. All these are core spatial features which are present in acromegaly. So if you have a patient who has these features with investigations and also have secondary hypertension, this could be potentially the cause of secondary hypertension. Thyroid disorders, interestingly, both hyperthyroidism and hypothyroidism can cause hypertension. Both have different mechanisms of action of how they cause it. And what do we look for when we suspect that we have thyroid disorders? Are the physical examination findings. Both of them will have different external features, reflexes, but both can present with myopathies or weaknesses in the proximal muscles. For the thyroid function test, we look for the TSH levels and the free T3 and T4. And hyperthyroidism, this would be low. Hypo would be the opposite. And the same principle applies to these two hormones in correlation with TSH. If the TSH was high, this would usually be low. If this was low, this will also be high, and vice versa. Autoantibodies can also be associated with each disease. For hypothyroidism, the one we think of is Hashimoto thyroiditis. Look for thyroglobulin antibodies. Look for also thyroid peroxidase antibodies. When we have hypothyroidism, we think of Graves' disease, and we think of TSH receptor antibody. And here are some of the features that you can see for hypothyroidism. You have the hair loss and with dry hair, periorbital edema. You can also have some features on physical examination and history, such as patient having feeling tired, lazy, depressed, increased weight, and also having constipation, feeling cold. And the opposite would be hypothyroidism, having heat intolerance, and also having bulging eyes. Both of them can present with goiter. It could be also tachycardia, it could be sweating, weight loss, diarrhea. So these are features that you can try to assess in history and physical examination when suspicion is secondary hypertension. Adrenal gland disorders now. So we go from top to below. We have the adrenal cortex and the medulla. Cortex have multiple layers. We're going to focus on the first two, the zona glomerulosa, which secretes aldosterone, So if you have too much aldosterone, this can lead to hypertension, and we call that, if it was primary hyperaldosteronism, we call it Conn syndrome. If we have too much secretion of corticosteroids from the zona fasciculata, then we call it Cushing syndrome. If you have from the adrenal medulla increased secretion of catecholamines, which includes epinephrine or epinephrine, we call it phemochromocytoma. We're going to talk about three of these now. For Conn syndrome, it's also known as primary hyperaldosteronism, because the secondary hyperaldosteronism also occurs. But for talk today, we'll talk about Conn syndrome. When do we suspect Conn syndrome? It's when we have electron imbalance, which is hypokalemia, due to the effect of aldosterone. It retains sodium and excretes potassium, so we may expect hypokalemia, plus minus maybe normal sodium levels, or hypernatremia. You can do some tests. There are multiple tests you can do, such as plasma aldosterone to renal ratio, ARR. You can also do an imaging study, such as CT scan of the abdomen, to check for possible mass, such as adrenal adenoma. A side note that this condition could be caused by bilateral adrenal hyperplasia, so not necessarily a mass. So it could be tricky that sometimes you may not find that much of increase or mass on abdominal CT, but it could be due to bilateral adrenal hyperplasia. So this could be a tricky one. Cushing syndrome is when you have increased level of cortisol in the body. And just on a side note also, Cushing's disease, it is one type of Cushing syndrome, but this is caused by adrenocorticotropic hormone secretory pituitary adenoma. So you have increased level of ACTH from the pituitary adenoma. This is one type of Cushing syndrome. Cushing syndrome also includes exogenous use of steroids. It could be also ACTH independent, so when you have hypersecretion from the adrenal cortex, and also when you have ectopic release of ACTH, such as in some cases of lung cancer. So what are the things that we look for if we suspect secondary hypertension and the Cushing syndrome? We look for physical examination findings, we're going to talk about later. You have some tests, multiple tests that can be done. An example would be urine-free cortisol, which would be increased. You can also do low-dose dexamethasone suppression test. Excuse me. You can also do an imaging, such as adrenal CT scan, so as you can check if the source is from the adrenals, or it could be extra-adrenal, as we talked about in ectopic release of ACTH from lung cancer, or if it was from the pituitary by pituitary adenoma. And here's some of the features of Cushing syndrome. You have thinning of the hair, visceral or red cheeks, hirsutism, acne, accretion of fat in the back, so the buffalo hump. You can have easy bruising. You can have also abdominal distension, purple striae, thinning of the extremities. All these are features that you will look for in Cushing syndrome. Phemochromocytoma is caused by increased levels of catecholamines, such as epinephrine or epinephrine, and this could be seen in some conditions such as multiple endocrine neoplasia in men, and seen in men too, both 2A and 2B. One of the hereditary syndromes that we look for, that can also ask in the history. Neurofibromatosis type 1 also can be a cause. What are the things that we look for? You can look for increased metanephrine, which is one of the metabolites of catecholamines in plasma or urine, which could be increased due to increased levels of catecholamines. You can also do some imaging study to see if there is a mass or tumor in the adrenal medulla. And just a side note, about 10% of cases can have extra-adrenal locations. So you may have manifestations of phemochromocytoma and the labs are positive, but you might find a mass in the adrenals. Then try to look for extra-adrenal manifestations or extra-adrenal locations, such as the sympathetic ganglia, which is a common location. About 10% of cases come from it. And these are some of the features that you can try asking the history for phemochromocytoma. This is classically associated with the 5 P's: pressure, which is hypertension, headache or pain, perspiration, sweating, palpitations, and pallor. And sometimes occurs as intermittent episodes, not continuous, so they can be and paroxysmal attacks. This is the 6P usually. So these are things that we look for in the history. And sometimes what they can also do is request the patient to measure the blood pressure when they have such symptoms at home, or when they can record it with their pulse. Both of them can be elevated because of the catecholamine release. So when ask them to measure the blood pressure and the pulse, and both are high, this could suggest or support phemochromocytoma. Respiratory diseases, one disease we should think of is obstructive sleep apnea, because this disease is sometimes also being underdiagnosed or undiagnosed, because it may not be manifested easily. So try to ask about it in the history, such as if the patient has a poor sleep quality, or patient has maybe waking up at night, having daytime sleepiness, or if one of the relatives or friends saying that he snores, and maybe if the patient has some features that present in the vitals, such as the patient has high BMI. This could be features supportive of obstructive apnea. This is one of the common causes that sometimes is underdiagnosed, unfortunately. So we should try to look for respiratory causes. Renal vascular disorders, we have the renal component. Disease affecting the renal parenchyma and the vascular, the vessels. So we have three for each. We have the chronic kidney disease, nephrotic syndrome, polycystic kidney disease. The blood vessels, we have renal artery stenosis and coarctation. Our dissection can be caused by hypertension, and sometimes our dissection can rarely cause secondary hypertension. So it could go both ways. Although you may find that artery dissection is actually caused by polyclonal hypertension. So patient would have known case of hypertension, they have very high blood pressure readings, and they're not complying with the medications, and this could be the cause of artery dissection. And vice versa, it could be artery dissection leading to hypertension. That could be the cause also. Chronic kidney disease is tricky because it can go both ways, similar to artery dissection. Hypertension can cause chronic kidney disease, and vice versa. So sometimes it's difficult to know which one came first. What are the things that we look for when we suspect chronic kidney disease? Look for external features for examination, like different other diseases that we have talked about earlier, such as like swelling. Sometimes they have classically described as earth-looking face or muddy face. Some of the features are sometimes itchiness due to one of the labs that we're going to talk about now. So lab studies include increased urea levels, which can lead to itchiness, maybe can lead to pericarditis, increased creatinine levels, low estimated GFR, hyperkalemia, anemia, and also metabolic acidosis. All these are features suggestive of chronic kidney disease. And also, patient may have diabetes, maybe, or they have glomerulonephritis, and it can cause chronic kidney disease, which can lead to hypertension, and also vice versa. Nephrotic syndrome and polycystic kidney disease. When do we suspect nephrotic syndrome? If the patient has hematuria, sometimes could be gross. We have also red blood cell cast in the urine, and we also sometimes have proteinuria, but it's not massive. Massive is seen in nephrotic syndrome, so it will be less than 3.5 grams and 24 hours in the urine. For polycystic kidney disease, we have two variants: autosomal dominant, autosomal recessive. Autosomal recessive usually seen in pediatric age groups. You may see it in infants or children who have kidney failure and also have hematuria. So for this case, we're talking about single hypertension, is we talk about autosomal dominant, because this is usually that persists to adulthood. You can find palpable kidneys, sometimes enlarged kidneys with cysts on by palpation of the kidneys when doing abdominal examination. And also sometimes have falciform history because it's an autosomal dominant, so you may have it also in the family members, so this can suggest polycystic kidney disease. Renal artery stenosis can be caused by two variants also: atherosclerosis. A patient has atherosclerotic risk factors such as diabetes, dyslipidemia, smokes, maybe family history as well. Pharmacological dysplasia is commonly seen in females, and the location is classically as approximately one-third is affected by atherosclerosis. Distal two-thirds of renal artery is commonly affected by pharmacological dysplasia. So what do we look for when we suspect renal artery stenosis? Is we have the renal blue upon auscultation, which can be seen in cardiovascular examination and abdominal examination, because also the imaging modalities, which depends on the kidney function. If the patient has renal dysfunction, we can do duplex ultrasound scan. If the patient has good kidney function, we can do CT angiography or MR angiography. And these are some of the classic features you can see for pharmacodysplasia: string on bead appearance, as you can see here in these two images, string on bead appearance. Foundation of aorta is also associated with some diseases that we should know about. Turner syndrome is one of them. It's affecting females who have one less X chromosome, so they have 45XO karyotype, and sometimes this disease is associated with bicuspid aortic valve. So what are features that we look for? For female patients, we look for features of Turner syndrome, which is examination, which we'll talk about now. Depression cyanosis, which is having cyanosis in the lower limbs and not in the upper limbs, so having normal finger extremities in the upper limb, but cyanosis in the lower limbs. This can be a cause by cartilage of aorta. Radiofrequency delay is also classically a cause that's seen in cardiovascular examination, and radiofrequency delay would suggest cartilage of aorta. Auscultatory findings can be present, and one example of such murmur is machine-like or continuous murmur. In the left infraclavicular area, that relates to the interscapular area between the shoulder blades. This is one of the members that can suggest coordination of the aorta. Here are some of the features that we look in a female patient which may have Turner syndrome, which has Turner syndrome and also have secondary hypertension as a cause due to coordination of aorta. Such patient would have short stature, weighing of the neck, lower posterior hairline. They can have maybe broad chest with widely spaced nipples. These features can suggest as the manifest Turner syndrome, so you may have to do karyotyping to check that there's absence of one of the X chromosomes, and you can also try to look for findings of coordination of aorta because it is associated with it. And then we have some drugs or medicines. Alcohol, chronic use, they can lead to elevated blood pressure readings, steroids as well. Sympathomimetics, such as seen with CNS stimulants such as amphetamines, cocaine, these ones can lead to it, or some ADHD medications can lead to increased blood pressure reading because these are stimulants. And the opposite of CNS depressants, such as withdrawal of CNS depressants, can lead to blood pressure readings. So the patient had alcohol withdrawal, this can lead to hypertension, as maybe benzodiazepine withdrawal, also opioids withdrawal, could be a cause, could be some CNS depressants. Some herbal remedies can also classically cause a blood pressure reading. Miscellaneous causes, which is the other causes, we have pregnancy-related conditions such as pregnancy-induced hypertension. So the female had normal blood pressure readings and then she became pregnant, and after 2 weeks of gestation she had increased blood pressure. This could be due to pregnancy-induced hypertension. Some other features added to it, it can lead to preeclampsia, which is a more severe form, and even more severe form than the preeclampsia is eclampsia, which have seizures. And finally, we have increased intracranial pressure, which can be due to tumors, due to space occupying lesions such as bleeding or hematoma. Think of Cushing's triad. One would be hypertension, the other two would be bradycardia, irregular respirations. This is summary of the code that we have talked about. We try to um, have it organized and classified in a good way so that we can remember the causes, and having it organized so that we can know what to look for in the history, what to look in the patient examination, and what do we also look for in investigations when having secondary hypertension. Thank you very much, everyone, and have a nice day.